Now I will go to the task which has been assigned, clinical suspicion of metabolic liver diseases. We have already talked about the settings yesterday. And I would like to address the adults. See, adults are not free from metabolic disorders. Dr. Misri has been pressing since yesterday that it goes on. And there may be expression in the adult, there may be expression in the pediatric, there may be continuation. So you look at the acute fatty liver of pregnancy. You look at the HELP syndrome, hemolysis, elevated liver enzyme, low platelet syndromes, basically a problem in utero because of the baby and manifestation in the mother, and because of the fatty acid oxidation defects. And I know on my floor on adult gastroenterology many times, these mothers actually die. They have problems. So you have to look into this beyond B and C, as you rightly said yesterday. We have to look beyond this B and C and fatty liver to look into those conditions and how we can prevent and diagnose them. Second thing, when we look at the epidemiological factors, incidence in Southeast Asia about aminoaciduria, organic acidemia, FAOD, these are the proportions which have been shown, and somehow the frequency is somewhat higher here, 1 in 2,000. That means they become important disorders. And this is the distribution. See here what I have tried to do, treatable disorders, hereditary fructose intolerance, galactosemia, congenital this is glycosylation defect, 1B, Woolman's disease, don't have much of treatment. Gaucher's, yes, enzyme therapy now, although expensive. Primary hyperoxaluria, yes, treatment. Niemann-Pick type C, no. Neonatal hemochromatosis, yes. Bile acid synthesis defects, yes. So many of these disorders do have the treatment. Although it may be expensive, maybe they will become less expensive over a period of time, but they can be available. There are people who can afford the therapy, they can go. And therefore, the recognition of these, most of these treatable disorders should be there in our country. When we look at children, see, these are the disorders which can go into the adulthood. So they have to recognize, as we had a case, adult case yesterday, Wilson's disease, Gaucher's, Niemann-Pick, glycosylation defect, fatty acid oxidation defects, urea cycle defects, they can actually persist and enter into adulthood. Therefore, they have to be alive. Then they should have the knowledge of these disorders. And then there are certain conditions which will present for the first time to the adults. Like here, many of these are there, citrullinemia type 2, primary hyperoxaluria. They should be known to the adult hepatologists, adult gastroenterologists, because they can be diagnosed and some of them can be treated. We need to have there, the family history becomes often important, which is not often asked in the adult practice. Diet history, past history of similar disease, it might be there in the patient and remains disease free for some time and then actually manifests. So that may be, that history may be there. This I already talked yesterday. Now the question is, what is the enzyme? What is the test we should use? You will forgive me because I am not a laboratory man. I may do certain mistakes here, but this is the best review which I have tried, Dr. Moinaksen, Sharma and myself, for last 40 days, and try to extrapolate what is the enzymes or what are the tests which can be often they can be offered. See here in screening for the hereditary fructose intolerance, fructose holes on electron microscopy. This could be for the screening. But the enzyme what we need is aldolase B. And labs in India, in fact, we don't have this enzyme. So if Neogen or Sandur lab group is available here, I request them kindly develop this enzyme, make it available, and there may be many cases, in fact, fructose intolerance in this country. And the best sample is the liver tissue. If there is coagulopathy, we can derive from the small intestine. In presence of coagulopathy, we can do from the small bowel mucosa. So this is the confirmatory test for fructose intolerance, and this is the enzyme which has to be demonstrated. Now, when we look at the Niemann-Pick disease, we have talked about it. See, important is here, see, type A and type B, what we understand, sphingomyelase deficiency, and detections are quite, but we are not very much. As pediatric GI liver people, our type C becomes very important, and this is not an enzyme deficiency. It is actually a trafficking defect. And not related to the enzyme. Where neurological involvement may be there will be liver involvement in different forms, and therefore what we need actually is for this particular type C Niemann-Pick disease, how we can diagnose and confirm. And this is a lot of talk. When we send, normally we used to send as MD residents to the histopathologist bone marrow, and they would give us foam cells. We would say, yes, it is Niemann-Pick or Gaucher disease. But it can occur in many conditions. This slide shows that it can occur in many conditions like gangliosidosis, Gaucher's, Niemann-Pick type A, C, Wolman's disease. So foamy cell is just an indicator but not confirmatory of these of Niemann-Pick type C. And therefore what you need another test to diagnose the Niemann-Pick type C. So what is that? What is available in the literature? So this is the bone marrow. This is what the enzyme which has been talked about actually for plasma levels for the Gaucher's disease. It is abnormal in Gaucher's also, and it is abnormal in Niemann-Pick also. But what is the definitive not available in India? That is the Philippines testing. This is the accumulation of intracytoplasmic unesterified cholesterol. This is to be developed in India, but it is not a lab. It is basically a histopathological. This is a staining technique that needs to be actually taught to our pathologists and hammer them, please do it. And this is the test basically, that is the Philippine test for Niemann-Pick type C, at least we can do that. And this is how the staining is there on the biopsies. So that is how we can do for Niemann-Pick type C. It is not the enzyme estimation for type C, it is actually the staining which can be done in this country. Wolman's, we have talked yesterday, and what is the enzyme? Supportive, hypertriglyceridemia, hypercholesterolemia, foamy histiocytes in bone marrow, liver, and the enzyme which is actually required for confirmation is the acid lipase enzyme. And this can be done from WBCs or skin fibroblasts. This is available in India. These laboratory these groups, they are actually doing this test, acid lipase, in India. So you can easily ask for this. Whenever you have calcification in adrenal gland, you have the manifestations, you can ask for this enzyme, it is available. It's also important for the antenatal diagnosis. See, one child has died. But we have to think about the next child, and that counseling should not be actually forgotten. That has to be told to the family. So you can do the from chorionic villus sampling less than 12 weeks, it can be done, and the antenatal diagnosis can be made. Now this is an important set of disorders, congenital disorders of glycosylation. See, basically we are interested in CDG1B, it's very important from liver point of view. They have hypoglycemia, recurrent thrombosis. Coagulopathy, it is not because of the actually deficiency of prothrombin. This is imbalance in the pro and anticoagulation factors. They have also the intestinal manifestation, that is the protein losing enteropathy. They may have congenital hepatic fibrosis, transaminitis, cirrhosis, or liver failure. And this begins actually in infancy. And what you see here, this is one of the disorders where the treatment is easily available. The oral mannose therapy, this is the dose which is given 5 times a day, and the child may survive into adulthood. So this disorder, identification, because it involves the liver. Second, manifestations are in the liver and the GI tract. Number 3, the treatment is available. And there is also a belief that now many people are saying that whatever cryptogenic liver disease, as Dr. Pramod was also telling us yesterday and today also, cryptogenic liver disease we should search for. And probably glycosylation, this CDG1B may be there, it may be responsible for actually cryptogenic liver disease, and if you diagnose it, you can actually give the therapy in these people. This is the glycosylation disorder, and here is the defect. And if you give the mannose in this condition, the pathway is maintained and you can actually treat this patient. This is you can also do the quantitative serum chromatographic carbohydrate deficient transferrin assay, you can do the qualitative. And qualitative isoelectric focusing of serum transferrin cathedral shift is currently being used in most of the studies, and commonly also used for the antenatal diagnosis. This enzyme assays, they are done in very few labs in the world who are actually the research labs. So I don't think we can ask the laboratory people here in India to develop it. In fact, they can develop this qualitative isoelectric focusing of serum transferrin cathedral shift. And I don't know how difficult it will be. Labs need to develop this in India because this is something which is treatable disorder. Now, regarding the fatty acid oxidation defects, I have shown this slide yesterday, but I would like to emphasize one thing here. Screening, we already know this biochemical path. We have shown yesterday what are the tests which are there. We have got GCMS, urinary organic acid, and all these assays available. This can be done in India, fatty acid oxidation defects, tandem mass spectroscopy for plasma carotene and all these carotene assays, they are also available and they can be done. And for the quantitative fatty acid analysis, I don't know how far it is really required in our country when the actually their diagnosis is difficult. The enzyme activity in the cultured skin fibroblasts or muscle biopsy, carotene deficiency also can be diagnosed by this. But this needs to be developed. If we have to progress, people are demanding, we have to ask laboratories to develop this enzyme assay. These are only the screening tests. Definitive tests are the enzyme activity assays for fatty acid oxidation defects. Respiratory chain defects, as I mentioned yesterday, plasma lactate, and many other provocative tests, these can be easily done in this country at our own level. Definitive tests, there are multiple of them because this disorder is huge. And what you need large samples. And most of the actually authors write, it's very difficult to develop at individual unless their labs are very research oriented. They have got the acumen of doing all those things. I think we also have the problem that respiratory chain defects, in fact, are not treatable. The outcome after treatment also is not really good. So this takes a priority 2, 3, 4 in my view. There's no need actually to go for all these tests right now. Organic acidemia, we have many among them which can be treated. Look at this, these two disorders over here. They manifest with liver failure, pancreatitis, neutropenia, vitamin B12 can be given. Here you can give the glycine and low protein diet. For this you can give the biotin, that is the carboxylase deficiency. They do well with this, but for other disorders we don't have the treatment. And therefore, identification of a subgroup of organic acidemia becomes important from treatment point of view. And here, this is how actually the distinctions among the different groups can be made based on urine ketones, ammonia, lactate, and the glucose levels. So the screening is by the urinary organic acid GCMS, which is available in India. Enzyme level fibroblasts is a definitive test, which is not available here. So here I would just show you among these, which looks very Greek to us. This is the patient who Dr. Moinaksen has seen at Nepal, Kathmandu. Recurrent encephalopathy, metabolic acidosis, skin exfoliations, this baby. And this patient actually had recurrent encephalopathy. And because of the skin problems, he referred this patient to HGP GI genetics department, rightly so. And what they did a screening for organic acidemia, and they found carboxylase deficiency, and this patient was put on biotin. And thereafter, this patient responded beautifully. So among the organic acidemia also, you have a group where you can offer the treatment. If we diagnose them, we can help them. So this is one of the examples. Kathmandu, you can realize the patient coming from Kathmandu, even HGPGI did not have this kind of screening. They had to send it to one of the private labs to do it and find out the defect. So these are the skin lesions, exfoliative skin lesions. Is very happy. Urea cycle defects, we know. We have talked about it. This is how they present to you in different manners. And they have hyperammonemia, intoxication, in the neonates also can manifest, recurrent encephalopathy, seizures, coma, and behavioral and psychiatric problems in the adulthood. And what we have available, this is the line which has been drawn. These are the plasma amino acids that we can do the screening in India. We have the labs available. All these can be identified. And along with that, you have to do urine or orotic acid. And these are the definitive, actually, methods do the confirmation of urea cycle defects at different levels. So definitive enzyme assays are mentioned here. Screening is available, which can be done in India. Analysis available, enzyme levels confirmatory, and these are the different enzymes which are done. And what are the tissues which are required? Fresh liver tissue, liquid nitrogen, fibroblasts, RBC for different kinds of disorders of urea cycle defects. And we have treatment available for some of these defects, benzoate, arginine, depending upon how you identify, vinyl acetate, and then of course liver transplantation. Bile acid synthetic disorders, defects. Normal, whatever we have discussed, NCS, rickets, no pruritus, and definitive test not available in India, plasma bile acid profile, lower absent cholic or chenodeoxycholic acid. They can be actually confirmed by the fast atomic bombardment tandem mass spectrometry, urinary bile acid metabolites, and I think our labs in India should develop it, because this is a treatable condition. This is where we can give the cholic acid and chenodeoxycholic acid, and we can prevent their progression into cirrhosis. Any lab who is sitting here, please note it down. We need to develop all this. In fact, Dr. Abba should communicate to these laboratories and tell what has been actually our opinion on development of different metabolic tests in India. You can recommend to them, and we can also help you. And this is how the bile acids can be looked at. This is a normal infant. This is a baby with cholestatic newborn, but no bile acid synthetic because the conjugates are there. Primary hyperoxaluria, we have discussed the case in the morning, which was a very nice case. Infancy 20%, childhood 50%, adults 20%, and the end-stage liver disease. In fact, that infant had end-stage almost renal disease, requiring actually this dialysis and other things. Death by 5 years. And what is the screening? Imaging is one, nephrocalcinosis, stones, RFT, GFR, 24-hour urine oxalate, plus these compounds, glycolate and L-glycerate, they have to be done along with. Liver biopsy is a definitive method, that is by the AGT activity, and then of course the gene mutations. But this is what can actually confirm the diagnosis in these patients. In the morning, we were asked a question, what should be the levels? We don't have the levels on oxalate in 24 hours. And these are the levels for 0 to 6 months, then 7 to 24 months, and different age groups. The levels are already given. So what is the summary? The last 3 or 4 slides. Hereditary fructose intolerance, treatable condition, aldolase B enzyme, liver tissue based small bowel biopsy, not available, important, should be developed. Abba? Yes. Niemann-Pick disease, Philippine testing, staining of skin fibroblasts, not available. We have to request our histopathologist to develop this. Labs cannot develop, this is a staining technique. Woolman's disease, acid lipase, WBC is the cheaper one as compared to fibroblasts. And available, and the lab Sandur is doing it. So this can be done. CD glycosylation 1B, isoelectric focusing screening, although not specific, enzyme is not feasible because most of the labs don't recommend. Serum transferrin cathedral shift has to be developed, not available, important and treatable condition. Glycosylation 1B disorder. And then when we see at the fatty acid oxygen defects, we have the tandem mass spectroscopy, we have got the chromatography, blood and urine samples, 2 labs. I know of these 2, I don't know, other one is in Bombay, I think I'm not aware of that lab. So confirmatory enzyme skin fibrosis not available, FAOD. But this is all right. This is good enough at the moment. Organic acidemia, screening, confirmatory enzymes in the skin and fibroblasts, not available. I think this should be all right at the moment. Urea cycle defects, screening, blood and urine available. Confirmation enzymes, skin fibroblasts, not available. But at times you may be caught. You may be caught. This is wrong testing, screening is wrong, confirmation is not there. You have done a transplant and something has happened. People are very fussy these days. They will say, why didn't you confirm? So we have to take cognizance of all those. Why you take the major undertakings like transplantation? You have taken a decision. We must have a confirmatory diagnosis. Bile synthetic defects, blood and urine not available, need to develop, and it is a treatable disorder. So we have to develop these tests. And lastly, primary hyperoxaluria, screening 24 hours, urine, India it is available. Confirmation, this test needs to be developed. Galactosemia, we are happy. Tyrosinemia, also we are happy in India at the moment, reasonably happy. And this is how the samples have to be sent. Before you send the sample, you must ask the concerned laboratory. Actually, Dr. Abba, we should take a small somewhere in this website, put what are the tests available with companies, what is their cost. You can ask them with permission that can be put, and people can easily access that and see. They have not to call everyone. When you call a company, first the secretary will come, then you will say whom to talk, he will say another one, then he will say which one, he is on the tour, then he will come on that day, that becomes a botheration. So if we have a ready reckoner available on a website, they should know how the samples can be sent, and that can direct our doctors. So this is, I would end with this, that there is a hope for developing, for identifying metabolic liver diseases in India. We can take the help of Dr. Priya, Dr. Pramod, many others, and we should also make effort at our own end to emphasize to different agencies, research centers in the country, bodies, to actually make a central referral lab. That will be a very big advancement for our country. Thank you very much.